Welcome to the PsychopharmaStahlogy Show, a special NEI Podcast series. In this show, Dr. Andrew Cutler interviews Dr. Stephen Stahl on the most controversial, novel, and exciting topics in psychopharmacology today.
Hello and welcome to another episode of the NEI PsychopharmaStahlogy Show. And with me today, of course, as always, is the one and only Dr. Stephen Stahl. Steve, how you doing?
Okay, good, guys.
Great. Well, we're talking about a very important clinical topic, which is something that has not been, I don't think, well addressed, and certainly treatment has been a challenge. And with us today, I can't think of anybody better than my good friend, Dr. Vladmir Maletic. Vlad, how are you?
I'm doing great, Andy, and I'm so glad to be able to join you and Steve for this very important conversation with wide clinical implications.
Yeah, it sure is. Well, of course, I want to talk about what is anhedonia and why should we care? Why should clinicians care? So why don't we just jump in and start out with, what is anhedonia? We're always sort of told it's experiencing pleasure, but there's more to it than that, isn't there?
You're absolutely right, Andy. When we speak about anhedonia, we commonly refer to diminished interest and diminished capacity to experience pleasure. But in addition to that, there are prominent cognitive components, so it does influence one's learning. And frankly, there is very compelling data to suggest that so-called reward learning is impaired. Let's put that into clinical context, right? Somebody has anhedonia. They are invited to meet with friends. Because of the anticipatory anhedonia, they're not too excited to do it. And already in their mind, they're starting to manufacture reasons why they cannot make it. But let us say that one of the friends prevails on them. They decide, okay, I'll go ahead and just go through it. I don't want to disappoint people who usually support me. And then they go through the experience, and the experience is mildly enjoyable. So that would be consummatory anhedonia. It is a little bit muted. But after that experience, if there was to be another occasion in the future, they would say, well, although I did have some reluctance and resistance, once I went through it, it was enjoyable. And I'm likely to repeat that. Well, with impaired reward learning, that is not the case.
Yeah.
Because they don't learn from their experience. They have to fight the same resistance the next time. So you're right, Andy. It has multiple different components. It's a much more complex phenomenon than we think many times. Yes.
Wait, so you're saying that anhedonia includes cognition, decision-making, perceiving the environment, thinking about things? What do you mean?
Absolutely. It colors. It permeates everything, right? It permeates our thought process. It permeates two phases, anticipatory and consummatory phase, and it, by influencing our thought process, it also influences reward learning. So it's a complex phenomenon.
You're saying that people can make bad decisions or inaccurate decisions?
Absolutely. Yeah, their decisions are no longer adaptive. They're not, in other words, by having that kind of stance and avoidance, they're actually diminishing opportunity to be supported.
Okay,
and,
so it's
it is biased. You're right. It's biased. It's colored.
Bias.
It's maladaptive.
Okay, more of a negative. Steve, what do you think about this? I thought anhedonia was just pleasure.
Well, I mean, there's kind of two kinds of pleasure, and I don't know what Vlad calls the different forms of them. One is I don't want to do it, but I kind of did it anyway or was forced to do it, and I kind of liked it anyway, surprisingly. And the other one is I don't want to do it, and I did it, and I didn't enjoy it.
Yeah.
So which one is it, Vlad? Are they both anhedonia by definition, or is that something else?
It's, frankly, it's a matter of degree. Because most of the time when people have anticipatory anhedonia, and that's what you described as, I don't want to do it, they will have a degree of consumatory anhedonia. I did it, but it wasn't as enjoyable as I was hoping it would be. It's not as enjoyable as it has been in the past when I was feeling well. But there are sometimes differences in magnitude. Some people will have more pronounced anticipatory than consumatory, and sometimes they'll be equally pronounced. The neurocircuitry involved in these processes is related, but it does not have all shared components. It's also a little bit different.
Well, let's talk about that, Vlad. That's interesting. There really are different neurotransmitter systems that are more associated with anticipatory versus consummatory.
Yeah, that is correct. That is correct. So, in terms of anticipatory, it relies more on cognitive parts of the brain. So it contains elements of so-called salience network, but also central executive network. Consummatory has a lot to do with nucleus accumbens, which is ventral striatum. That is the main reward area in the brain. But it also is in relationship with amygdala and limbic areas. And this is clinically very important aspect of it. That dialogue between perception of threat and danger and enjoyment is ongoing. In other words, feeling distressed, feeling anxious, feeling threatened, traumatized is enemy of activation of reward centers, both in terms of anticipatory but also consummatory anhedonia. So in other words, there are two ways we can try to work on decreasing stress and perception of stress, which may improve our ability to anticipate and enjoy good things in life, or we can try to directly influence reward network and increase that gain, if you will. Most of the time, we actually end up doing both.
Right, and my understanding is that anticipatory is a little more weighted towards dopamine, and consummatory is a little more opioid system.
Indeed, significant involvement of opioids, and again, not to omit very important data, because ultimately monoamine receptors endow glutamatergic fibers. So the entire communication between cortex and relevant parts of striatum is conducted by glutamate. And it is informed and guided by monoamines. So impairment in glutamatergic transmission, both not enough activation of dopamine in ventral tegmental area and substantia nigra, that can be part of it, but also diminished activation of nucleus accumbens and reward areas of striatum would be compromised. And we have pretty good idea now that glutamatergic agents such as ketamine and ketamine, data is actually more available when it comes to ketamine, not only help anhedonia in major depressive disorder, but actually help anhedonia in individuals suffering from bipolar depression too.
Interesting.
So I would say dopamine, opioids definitely in terms of neurotransmission, and glutamate seems to have a significant role.
Can we actually use the concepts of liking and wanting rather than anticipatory and consummatory, just for the sake of the listeners here?
So let's say this way. Wanting is more anticipatory, more dopamine. Liking is more opioids, consummatory.
Well, one of the analogies to that is the idea that when you are addicted, you have your dopamine go up when you're thinking about having it. So when you're touching the crack pipe, when you're actually, opening the cigarettes, when you're pouring and smelling the coffee, whatever it is, that's when the dopamine goes off.
That's right. Makes you want it more. That's right.
Yeah. And then of course, if you actually consume it, that's consummatory. And then, that's great. It's pleasure. The problem with addiction, of course, is that you want it, but then it's not that much liking. It just stops your dysphoria, and it's you don't get the big kick anymore. But listening to this podcast, you see it on the email invitation to the listeners, and they want it. And then, of course, they listen to it, and then they like it.
I hope they will like it, yes.
I'm sure they will, yes.
And those systems, I'm talking about dopamine and endogenous opioids, are in delicate balance.
Yes.
And frankly, human nature has not helped us because it appears that our brain is not programmed to experience enduring intense pleasure. Because no sooner have we activated these wanting dopamine fibers that originate from ventral tegmental area and project to the reward area, nucleus accumbens. But nucleus accumbens sends a loop right back to ventral tegmental area. And that loop utilizes dynorphin and GABA and inhibits the release of dopamine.
Yes.
Right.
Boy, that's
and
nasty.
the more we repeat it in individuals who have problems with substance use, the more we repeat it, the pleasure does not become more intense. The inhibition of pleasure becomes more intense. And the new baseline is kind of a dysphoric state.
This is like a hamster on a wheel. It's a negative feedback loop almost.
But what about things that don't cause you to tolerate to it, like this webcast? If you listen to it many times, you'll still enjoy it each time. I'm teasing, but aren't there things that
very well may be true?
Yes. Well, is it a matter of degree? I mean, in substance abuse, there's an intense, rapid sense of pleasure.
Correct.
Is that different from a more ongoing kind of enjoyment?
It is, and in terms of even pleasure, there is so-called hedonic pleasure, and that would be, Steve has already listed, listening to jazz, taking a walk on the beach, enjoying dark chocolate, sexual activity and exercise can also provide some of that hedonic pleasure. But there's a different kind of pleasure that some people refer to as eudaimonic pleasure. And that is a pleasure of having kind of a spiritual awakening, engaging in altruistic acts, helping other people. All that is associated with pleasure. But it is a little bit different in terms of neurocircuitry. It is more kind of a slow burning pleasure, as you hinted at, Andy.
Okay, well, that makes sense, certainly. Well, I want to get into treatment in just a minute, and we've started to talk a little about neurobiology, which of course can inform our treatment. And I have to tell you, Steve, this was your original concept for forming NEI many years ago, was being neurobiologically informed in your treatment. And so I want to get into that in a minute. But first, why should we care, Vlad? Why should the clinician care about anhedonia?
Why should they care? Andy, I'll just mention few more statistical associations between anhedonia and some clinical features. So presence of anhedonia, unfortunately, is a negative predictor of response and remission with SSRIs.
I see.
So if there's a prominent anhedonia, SSRIs may not be appropriate treatment for that patient. There is high association between anhedonia and treatment-resistant depression. There is a strong association between anhedonia and severity of depression. And last but not least, anhedonia is associated with suicidal ideation.
Wow.
Particularly let's now use all the names. The wanting anhedonia, the anticipatory anhedonia, that is the type of anhedonia that has, again, strong association with suicidal ideation. And Andy, just think about it. If individual does not get excited and interested in anything in life, sooner or later they're going to ask the question, what is the point?
What's the point? Why should I go?
Yeah.
And what about the idea of neurobiology, Vlad? This was something that people like Trevor Robbins, who's a famous neurobiologist from Cambridge, were talking about. The ventral to dorsal shift. The idea that ventral striatum is due to new or relatively novel kind of pleasures, and then you really want to have them by a hedonic drive, if you will. And then after you've done it for a while, it seems to become an automatic behavior where you actually are becoming like a Pavlovian dog. What used to cause you to have pleasure when you saw it, like anticipating chocolate cake or whatever, and then you actually even this is a binge eating kind of a scenario where you actually then you're eating, but you're not hungry and you're not satisfied, and that it becomes a compulsion, and
right.
It's not really driven by pleasure anymore. But it's just sort of like you're doing it automatically. You wonder why people, take drugs compulsively, even though they lose their marriages, their money, they're living in homeless. Why do they do that? And it's almost like they're a Pavlovian dog. They're around stuff that makes them want to seek drugs, and that's their whole life. And then they do it, and they just it's an automatic behavior. What? Is that something you believe in? Yeah,
I do. I do. And Steve, this is very consistent with neurobiology, and particularly with neurobiology of the striatum, where striatum essentially has three different components. So
right.
Ventral striatum is more kind of affective, emotional. Nucleus accumbens is part of ventral striatum. That is the one where we're experiencing pleasure and excitement. Then there are portions of striatum that are more lateral and dorsal. And these portions of striatum are more associative striatum. So it involves more thought process, and it involves more motoric activity. So something that started off being pleasure may now become associated with certain kind of cognition and certain kind of motoric behavior that tends to be repetitive. So in neurobiological sense, it very much makes, there's a logic there. And, you're obviously a famous pharmacologist. It's interesting that distribution of some of the dopamine receptors is also different. So that ventral striatum has more D3 receptors, and that associative motor striatum have more D2 receptors.
Yes.
So there may be pharmacologic differences there as well.
Yeah, I've always thought that there was a sort of a similar to OCD and substance abuse and binge eating. There's this OCD component, and we know the striatum is so critical to that, the pathology.
Well, this is interesting because it could give us a substrate for treatments because
right.
Overall, though, we don't treat hedonic problems very well. I mean, we have all these people on the street abusing drugs. There's essentially no treatment except forced abstinence, quite frankly. Right. And one of the things that's always confused me is that despite the fact that the animal models for addiction and hedonia are fairly close to human models, much better than the animal model for schizophrenia, let's say, we haven't been able to exploit that to give profound treatments. There's anhedonia associated with cognitive problems of dementia. There's anhedonia associated with mood disorders, particularly depression, right?
PTSD, right?
PTSD.
ADHD, schizophrenia.
Exactly.
You're absolutely
all
right.
these things, and actually these are the residual symptoms often that are not touched by current treatments. What's wrong with our treatments, Vlad? What do we have to do?
Steve, both you and Andy have actually published some interesting studies and interesting pharmacologic review articles. So there seem to be some strategies, and you have hinted at the importance of dopamine. As we know, there are many ways we can skin the cat. So one way of increasing dopamine in ventral tegmental area, there are GABA interneurons that tonically inhibit dopamine transmission. Well, those are endowed with serotonin 2C receptors. So if we block these serotonin 2C receptors, the outcome may be increased dopaminergic output, which would theoretically help. And indeed, there are studies using agomelatine medicine that is not available in the United States.
Yes.
But it specifically improves hedonic tone relative to use of SSRIs.
Yeah, Vlad, I did a study. We were trying to get it approved in the U.S., and I'll never forget a woman coming in and talking about how much pleasure she was experiencing. As a matter of fact, she recounted she started having sex with her husband again. And that was with that medicine.
Right. So there is another strategy, which is really intriguing. While cortex has really low concentration of D2, D3 receptors, it's about 100 to 1,000 times less than striatum. They're there.
Right.
But the main dopaminergic receptors in the prefrontal cortex is D1.
D1.
Now, what I'm about to share with you, data are not speculative. Our conclusions may be speculative. But there is a new antidepressant agent that is a combination of dextromethorphan and bupropion. Mm-hmm. But in addition to that, it is a modest D1 agonist. And there are data with this dextromethorphan bupropion combination in MDD patients where there was improvement in anhedonia as measured by MADRS anhedonia subscale. Mm-hmm. So yet another instance where we speculate the dopaminergic agent may be helpful. And finally, there are a couple of studies, small studies albeit, where bupropion, which is norepinephrine dopamine uptake inhibiting agent, was compared to SSRIs and indeed did result in improvement in hedonic tone. Yeah. So various dopaminergic strategies seem to provide a path to helping.
Okay, I want to get more into treatment in a minute, guys. I still want to set the stage a little more here. So, Vlad, in addition to those issues you talked about why we care about anhedonia, anhedonia is actually highly correlated with functional impairment as well, along with concentration difficulties.
Absolutely so, Andy. Anhedonia is associated with functioning. Anhedonia is correlated highly with quality of life. Mm-hmm. And if we look at the correlative studies, of course, both of you are aware of this, but anhedonia is correlated with cognition. Anhedonia is correlated with psychomotor retardation. Yeah. So, as a matter of fact, melancholy depression is essentially anhedonia and psychomotor retardation.
Certainly
interesting to point out our colleague from Belgium, Koen Demittenaar, did a very interesting study where he asked patients and he asked treaters what they wanted out of treating, let's say, mood disorder like depression. And the treater said, let's take away the bad symptoms that come up. Let's take away the guilt. Let's take away the new anxiety, etc. And that's not what the patients wanted. They didn't want you to take away bad stuff. They wanted you to restore good stuff.
Exactly.
So they were interested in where's my basically pleasure. And so often we're not even on the same page with the patient because, oh my goodness, this horrible new sadness is gone, and your guilt is gone, so I'm done. And the patient said, well, wait a minute, my joy for going to work is not restored. And so if one takeaway from this kind of story here is that although we really don't maybe have the most robust treatments to try tomorrow, at least we should try to recognize anhedonia when it's there and to try to treat it as much as we can, because sometimes SSRIs actually make you have anhedonia.
Exactly.
And so that's kind of the point. The patients want their anhedonia gone. They want restoration of joy. They don't want diminishment necessarily as the highest priority of agony.
That's right.
It's interesting.
Right. Well, Steve, I think there's many problems here. One is clinicians are not well trained how to assess anhedonia. So that's why I started with Vlad with the definition. Much more complex than just what we're taught.
Right.
Right, number one. And number two is I think we adjust our expectations to what our treatments can do. And SSRIs and SNRIs don't treat anhedonia very well. When you raise serotonin, you downregulate dopamine, for instance. Right, Vlad?
And both you and Steve hinted to something that with antidepressants, we may actually contribute to anhedonia. And this is a very interesting clinical dilemma. Because when we boost serotonin, yes, we will diminish negative affect, but we may also compromise positive affect.
Exactly.
And therefore, differentiation of these two phenomena, anhedonia versus emotional blunting, becomes very important in clinical practice. So if there is diminished positive affect, but on the other hand, enhanced negative affect, this is prototypical for anhedonia. But if there is diminished positive and diminished negative affect at the same time, this is more description of emotional blunting.
Yeah.
And
So
unfortunately, that's something with serotoninergic agent we tend to see. We tend to see emotional blunting.
This is the classic dilemma. Is it the illness or the treatment? And, of course, we think about sexual dysfunction as classically, which is, of course, a form of anhedonia.
And it's a proxy. It's actually a proxy to anhedonia.
Yeah.
Those two seem to be interdigitated. So whenever there is profound anhedonia, invariably sexual functioning is compromised.
Yeah. Okay, so we've defined anhedonia. We've talked about why should you care, and I think Steve brought up a terrific wrinkle in that, which is our patients care. It matters to them.
And Steve mentioned one good study. There's also Mark Zimmerman's study, right?
Yes.
Where there's a set of expectations that clinicians have as positive outcome in treating depression. But then he went on and asked the patients. And the two things that they appreciated the most is I want to be my usual self, and two, I want to be able to enjoy life again.
Yes,
so if you take items that are important to patients, they're actually much better predictive scales and much better predictive indicators of improvement in depression than what clinicians believed would be important.
Well, the problem is, again, partly our training. We are trained, we have to focus on symptoms because you need X number, 5 out of 9, to qualify for the diagnosis of depression. Our classic rating scales, certainly the ones that get drugs approved, are symptom-based. And so it's no wonder we sort of focus on symptoms and the patients are focusing on other things, function and quality of life.
Yeah. Yep. And ability to enjoy life.
Yeah, absolutely. That feeling of vitality, of feeling like myself again, So, I mentioned also that not all symptoms are born or created equally. I think we don't assess anhedonia thoroughly or carefully because we don't have good treatments for it, and yet it's highly correlated with functional impairment, as we said. So let's talk, and we've defined the issue that our standard treatments, our most commonly used treatments, certainly for depression, don't really help anhedonia and may worsen the problem, as we've said. And then we did also mention, I thought Steve did a great job mentioning the transdiagnostic nature of anhedonia, which brings up issues of, does that affect how we treat other conditions? But for the minute, we'll talk about, I guess, treatments focused on depression. We can talk about unipolar and bipolar depression. So you started to list a few. Why don't we go into, let's do this a little bit by mechanism. Let's start out with glutamate, since ketamine, is the prototypical non-monoamine treatment. Let's talk about NMDA receptor antagonism and how glutamate treatments might help.
It is one of the, I would say, more established mechanisms.
Yeah.
So although they're NMDA antagonists nominally, these agents actually enhance glutamatergic transmission.
Yes. That's the paradox, isn't it?
But actually, Vlad, too, they cause a flurry of dopamine release downstream as well.
I was about to say.
I gotcha.
Steve's
you preempted
impatient.
me, Steve. You're absolutely right. There's increase in dopamine, and in somewhat controversial, possibly involvement of opioid signaling.
Yes.
Again, it's quite controversial.
Yes.
But that's another possible correlate. And then, not to be forgotten, a prominent neuroplasticity, as in we actually see emergence of new synaptic endings within 24, 48 hours after the treatment. So they start rewiring the brain. More dopamine, rewiring the brain, greater activation of reward areas, and clinically significant improvement in anhedonia.
And cognition to some degree, right?
Cognition. There are data to that effect too. Absolutely.
Yeah. And we mentioned, so there's ketamine, there's intranasal S-ketamine. You mentioned dextromethorphan, which is also a moderate NMDA antagonist. So it is almost a ketamine-like, and it does have, of course, the sigma-1 agonism, which also, I think, relates to this we're talking about, doesn't it?
It's a very complex compound. Obviously, I'm preaching to the choir here. But to say, yes, it is a moderate NMDA antagonist. It's a sigma-1 agonist. And it is also serotonin uptake inhibiting agent. So
That's right.
it does have multiple receptor activities.
You mentioned a little bit of D1 as well. So. That's interesting.
D1 I was referring more to lumateperone, but indeed, yeah.
Oh, I thought you mentioned this one. Okay, great. Yeah. So we'll talk about, why don't we do that? Let's talk about atypical antipsychotics. There are at least two that we think might be helpful. You mentioned lumateperone. The other one is cariprazine.
Correct. So lumateperone has information in bipolar 1 and 2 depression, where, again, looking at proxy of improvement in anhedonia, which is MADRS anhedonia subscale that includes 5 items: reported sadness, observed sadness, loss of interest,
lassitude,
lassitude, emotional blunting, difficulty with concentration, right? These items reflect anhedonia. And indeed, there was improvement with lumateperone. There are studies with cariprazine, both in bipolar depression 1 and in MDD, where also MADRS anhedonia subscale improved. And there is one, and it's not very well-known study. It's from Marty Katzman and his group in Ontario. I believe they're in London, Ontario.
Yeah, I know Marty. He's a great guy.
Yeah, and they have found some improvements in anhedonia with brexpiprazole.
That's interesting, and that makes a lot of sense, actually. Let's talk a little about cariprazine's mechanism. Isn't some of that going to be D3?
So cariprazine is really interesting. It is D3, D2, partial agonist-antagonist. And here it's quite different because when it comes to D3, it has very, very high affinity, a couple of orders of magnitude more than dopamine itself. But on the other hand, its intrinsic activity is pretty high. So its intrinsic activity is about 70%. So think about it as 30% discounted dopamine.
Okay.
And its intrinsic activity at D3 is actually very similar to an anti-Parkinsonian medicine, pramipexole.
Yes, right. So there you go. So that's improving the pleasure.
And by the way, pramipexole, the D3 modulator, partial agonist-antagonist, does have evidence of helping anhedonia, both in unipolar and bipolar depression.
Yes. So
what about the possibility that some of these drugs cause gambling? Is this possibly making too much lack of anhedonia? Is it possible too much of a good thing happens?
Speculatively, Steve, I think you are right on target because it is a curvilinear relationship, right? And it's kind of Goldilocks principle. We want to get it just right. If we overdo it, it may lead to gambling and other impulsive activity and get people in trouble. And it's interesting that there is a typical antipsychotic that has that warning. And as you mentioned, anti-Parkinsonian medications, including pramipexole, will also have that warning.
Yes. Yeah, so aripiprazole and brexpiprazole, 2D2 partial agonists, currently have that. Cariprazine at this point does not have that warning. But I wouldn't be surprised if it did get it at some point.
Do we have to put a warning on this webcast? A warning, too much joy could be bad for you?
Could cause
maybe we're not that good. Maybe we're not that good. I don't know.
It is aspirational.
Yeah, that's right. It's a compulsive listening disorder, yeah. Okay, I want to move on now. You mentioned agamelatine, which is very interesting. It also works through the melatonin. It's a melatonin agonist, which also is related to this. And then that's not available in the U.S. But one that is available that I know our friend Roger McIntyre has published on this is vortioxetine.
Indeed. Vortioxetine actually has really interesting data where it helps with that entire Bermuda Triangle of tough to treat depressive symptoms.
Yes.
So they have evidence that it helps with cognition, at least processing speed. They have evidence that it helps with anhedonia.
Yes.
It helps with emotional blunting, and they even have evidence that it helps some with psychomotor retardation.
Yes.
So these tough-to-treat symptoms seem to be responsive. Again, we can speculate how it does it. One of the attributes of this medicine is that it is serotonin 3 receptor antagonist.
Yes.
Serotonin 3 receptors in the prefrontal cortex have only one location. They're on GABA interneurons. So if we block those serotonin 3 receptors, we will decrease GABA tone, will indirectly increase glutamatergic output from the prefrontal cortex. As we know, those fibers will travel to brainstem, and therefore there is a greater likelihood that they will stimulate some of the monoamines. And indeed, microdialysis studies with vortioxetine do suggest that most likely indirectly this medicine is associated with increased release of dopamine, norepinephrine, but also glutamate and acetylcholine.
And also it's a 5-HT1A agonist, which also can enhance.
Is associated with the increase in dopamine transmission.
That's right.
Absolutely.
That's right. And that may actually be part of the mechanism of nausea with that drug. Is that?
Yeah, it very well may be. And in one of the preclinical studies, blocking serotonin 1 receptors resulted in significant reduction of antidepressant effect associated with this medicine.
Interesting. So it's 5-HT3 antagonism, 5-HT1A agonism, amongst other things. Yeah.
Yes.
And I think that was the original rational design of that drug, was to do those two things in addition to SRI activity.
And serotonin 2A antagonism too.
Yeah. Interesting.
But the issue is in the marketplace. I'm not sure that that signal has been either recognized or enjoyed. It's either it's more theoretical than real, or it's just got diluted in the mess of giving everybody this drug. Because I'm not sure vortioxetine is sort of branded, if you will. It's almost generic now. I don't mean that in that sense, but I mean it doesn't have a reputation, let's say, of doing these things. Otherwise, they'd be used more. Is it maybe that they should be used more, or that the data are not robust enough to really tell a difference with other antidepressants?
There are very few head-to-head comparisons. There are some meta-analysis. So there is a meta-analysis by Bernie Baum looking at changes in cognition measured by digit symbol substitution test, and compared to a number of SSRIs and SNRIs, there was greater improvement on performance of this cognitive task with vortioxetine. But again, it's not head-to-head. There are head-to-head studies in terms of, if we think about sexual side effects as proxy, in patients who are treated with SSRIs and SNRIs stable and then switched to vortioxetine, sexual side effects diminished relative to SSRIs and SNRIs. Yeah. So, Steve, you're making a good point. Number one, there's not as much commercial interest to pursue those studies as far as U.S. market is concerned. But these aspects of this medication are definitely, you have been involved with some of those programs. I know Andy has been involved with. In Asia and outside U.S., it is something that is brought up.
Yeah. Well, I think there's a bigger problem. I think the data are very clear. As you mentioned, the sort of Bermuda Triangle, I like that analysis. I think the problem's more commercial, that it's hard to differentiate this drug enough meaningfully from SSRI, SNRIs, for insurance companies to jump on board, for primary care especially to push hard enough to get it. So I think there has been that issue. And I agree with you, Steve, that maybe the anhedonia word hasn't gotten out. Maybe that would move the needle more than the cognition did. Yeah. If I could, let's move on. There are a couple of things so as far as what's on the market, and then of course we didn't mention stimulant augmentation is certainly another way to address this. There's a long history of stimulants being used for depression. That's a whole other story. Let's talk about a couple things in development. We talked about the opioid system. Vlad, what do you think of these kappa opioid antagonists?
And I know both of you are involved in consulting and the development of two kappa opioid antagonists, at least that I know of. There may be more.
There is one other,
There is one other, yes. And the early data are promising, and it's really interesting that they seem to be more targeted towards patients who have major depressive disorder with prominent anhedonia. And even some of the scales that are used in the trial SHAP, Snaith-Hamilton pleasure scale, and DARS, dimensional anhedonia rating scale. They're actively and prospectively utilized in these trials. We have preliminary evidence, phase 2. They're in phase 3 now. And it's, again, preliminary evidence, I would say, is encouraging. And
What's
that's
the
kappa.
rationale?
Well,
What's the mechanism?
I mentioned that feedback loop, right?
Yeah.
That uses dynorphin and uses GABA to inhibit ventral tegmental area.
Yeah.
Well, dynorphin acts through kappa receptors.
Aha.
So if we block kappa receptors, we have cut that inhibitory, that brake cable. And therefore, nucleus accumbens, the reward area, no longer has that negative feedback loop where it shuts down dopamine transmission.
Interesting. So
at least theoretically,
that's
that's how we conceptualize it.
Yeah, kappa antagonists appear to have evidence for antidepressant effect, anti-anhedonic effect, also stress resilience and anxiety, which we know how important that is to depression in our patients. There's a couple of those to keep your eye out for, and then there are orexin agents that are being looked at. Do you think that might have some promise?
It might, because orexin is intimately intertwined. This is not going to sound very, but it is intertwined with monoamine modulation. And orexin is involved in shutting down catecholamines, and therefore orexin antagonism may be a helpful feature. It is part of, amongst others, sleep-wakefulness regulation. There is some evidence, obviously, appetite regulation. But orexin inhibition would shut down wakefulness.
Yeah. So there are a number of these drugs in development. One other one we forgot to mention, that it's a moderate NMDA antagonist, is one that I know Steve and I have been working with, and that is S-methadone, the isomer of methadone.
Indeed. I've not had chance. I'm aware of their depression data. I've not had chance to see if they've done any work specifically on anhedonia. You may be better informed.
Not yet, although they're using the MADRS, so we certainly could use the MADRS anhedonia subscale, and I will certainly push them to do that if we get to that point.
And it correlates pretty well with SHAPS, so it definitely would be useful.
Yes. Well, we've mentioned SHAPS and DARS, and unfortunately there are not a lot of clinically useful scales for this, because those scales are more appropriate for research, I would say, and they both have their strengths and limitations. But I think just us talking about this, hopefully, will raise awareness and will get people to just ask some more questions and really assess this more thoughtfully, because of how important this is and how it's been overlooked. Would you agree, Vlad, as far as helping our clinicians to figure out how do I assess this?
Absolutely. And, there's a pearl of wisdom. And, Steve, please correct me if my memory is not as accurate. But I remember at this point, it's a couple of decades ago, in one of your talks, you asked that we should inquire with our patients about 3 pleasurable activities that they have been engaged in and they've stopped doing, right? Anything from playing golf to baking cookies to playing bridge and so forth. And then following that through as we look at clinical outcomes related to treatment. Are these pleasurable activities? And that really, Andy, would you agree, that is available to all of our colleagues?
No, you've just talked about creating a personalized rating scale, Vlad.
It's a personalized rating scale.
It's a rating scale. You're just systematically following something
exactly
that's important to the patient.
It was in the spirit of trying to show remission, that you're not really completely well until your pleasurable activities are restored, but they're unique for each of us. I remember one lady, had to tend to her roses. And when her rose garden, you could almost look in her backyard and see what her mood was. If the roses were shabby, then she wasn't in good shape. But when the rose garden was tended to, and so they're very unique things to each of us.
Of course.
And you're right, Andy, that all we have to do is ask about those things, and then figure out we're not really done until those things are better. And patients really respond to that, to say, oh, you get it, you understand me.
Yes.
And, and then they may themselves have not really realized that they have lost those pleasurable activities, and somehow just trying to almost force yourself to go out and look at the roses. Sometimes it actually reawakens things and gets your engine going again. So I remember that. That was a long time ago. I did some videotapes on that. You got a better memory than maybe our commander in chief, but that's another another
thing. Or his challenger, I would argue. They both have issues.
Right, exactly.
Anyway,
no pun intended, but being able to smell the roses again is a good thing.
I love that. Smell the roses, wake up, smell the coffee, smell the roses. One final thing before we wrap up, guys. We've got to talk about exercise. Exercise helps with anhedonia, right?
Andy, exercise is very important. And there are other low-tech approaches that are quite important with anhedonia, where we actually have empirical evidence. So we know that CBT can be very helpful with anhedonia.
Yeah.
There is something that is called behavioral activation treatment for anhedonia.
Oh, my.
So this is a form of activation treatment that is, at least based on preliminary research, remarkably effective when it comes to anhedonia. And at the same time, it also reduces negative affect.
Wow.
So that is something that is important. And something else that is a neuromodulatory treatment. Mm-hmm. There are several now studies showing that RTMS can help with anhedonia.
Yes.
Especially theta burst therapy and also some evidence that ECT can help improve anhedonia.
Wow. Well, thanks, Vlad. This has been very comprehensive. Hopefully it's been extremely practical and helpful in getting our audience to think about anhedonia, to understand the complexity of the construct, to assess it better. And we actually have some tools available today. These are not just far-off research things. There are some treatments we've talked about, both pharmacologic and non-pharmacologic, that can be used right now today in your patients to get to what Steve was talking about, which is get people all the way back to themselves, get them better, get them to smell the roses, as we say.
That's right.
Well, gentlemen, that's all the time we have for today. I want to thank both of you for a really enriching discussion. Steve, any final thoughts?
No, I think that it's just need to reawaken our point of view. It's a little bit like one of those things, you get what you ask for. And so if you ask for somebody's anhedonia getting better, there's a possibility that will happen, even with the blunt tools we have available today.
Yeah, okay. And Vlad?
I just want to thank our audience for listening to our podcast, and both of you. It's always a pleasure to chat with you and hear your insights.
Yes, it is, certainly. And hopefully you and the audience have found this to be an effective treatment for your anhedonia. As Steve said, I hope you found this pleasurable and useful and valuable. And for more educational offerings, please visit our website, www.NEIglobal.com. Thank you so much, and have a wonderful day, and good luck with your clinical work.
Thank you for joining us for another episode of the NEI Podcast. Please let us know what you'd like to hear more about by leaving a review. Don't miss another episode. Subscribe today. For more information about NEI and our premier educational content, please visit NEIglobal.com.